Hi, everybody. This is the video for complications in pregnancy. So, what causes a pregnancy to be high risk? There's a lot of different things that we consider for this. Sometimes it's just the pregnancy is high risk, just based on the pregnancy. So things that like multiple gestation and things like that can just cause it to be high risk. But then there's other factors that can contribute to a high risk pregnancy. And so some of those things are things that we've learned about before, like psychosocial factors, behaviors, decisions that women make to use drugs, alcohol, smoke cigarettes, things like that, because those can affect the way we grow our baby. It can be biophysical factors. So it can be things like her pre-existing medical conditions. So if she has a history of poorly controlled diabetes or hypertension, those things are going to increase her risk for her pregnancy. It can be genetics, it can be nutrition, it can be a lot of different things. Okay. Also, things that we consider for this are things that they can be exposed to. So teratogens are things that can be in the environment that could affect her pregnancy. And early in pregnancy, in the embryonic period, some of these things can even lead to miscarriage. And then the other thing is our socio-demographic factors. So lack of access to care, financial situations, things like that. So for assessing fetal well-being, there's several things that we do to kind of make sure that the baby is growing well, doing well. And a lot of this is just our things at every prenatal appointment when we're checking mom's vital signs and we're checking how the baby's growing, we're measuring the fundal height. All of those things can give us an idea. But the other things we're thinking about for this, so alpha fetoprotein, this is something we can test for in mom's blood. And if the level is low, then it can indicate Down syndrome. And if the level is high, that can indicate a neural tube defect. So that's part of a blood test that moms often get around 12 to 15 weeks gestation. Biophysical profile. A biophysical profile is something that we do. This is a test we would do if maybe we were concerned. So if maybe mom hasn't been feeling baby move, or we already have evidence that the baby's not growing well, we have an intrauterine growth restriction, and we're watching that baby closely, things like that. So what happens with the biophysical profiles is a series of things. So they will do a non-stress test. And with the non-stress test, we put a monitor on the mom's belly and we listen to the baby's heartbeat. And it makes a tracing. And so we can watch for fluctuations in the heart rate. And so we look at the heart rate and then we also do an ultrasound. And on the ultrasound, they're looking for several things. So one way that we can remember the things they look for biophysical profile is it's like Batman. Okay, so B is going to be breathing. We're looking for fetal breathing movement. So even though we know the baby's not breathing oxygen, the baby's diaphragm drops and goes up because the baby's body breathes in amniotic fluid. T is for muscle tone. Okay, does the baby look really floppy or is the baby kind of tucked in? M is for fetal movement. Is the baby moving? A is our amniotic fluid level. All right, are we having a normal amount of amniotic fluid? And then N is our non-stress test. So it's not a perfect Batman, but it's close. So we look at all of these things and we give it a score. And that score, each category gets 2 points. And so that score then gives us an idea of how the baby is doing. And it can detect then if our baby is very compromised, and it can give us enough information to decide if we need to deliver her. So that's the biophysical profile. The daily fetal kick counts. This is something we teach moms to do at home, usually after like 28 weeks gestation. And they just notice, you typically do it at the same time each day. And they notice how many times they feel their baby move in an hour. If they get 10 movements in the first hour, then they're done counting. If they haven't gotten 10 movements yet, they'll count for the second hour. We want 10 movements in 2 hours. And if they're getting less than that, they should call. Typically, really what we'll have them do is maybe drink some juice and lay down on their left side and count for another hour. But if they're concerned and their baby's not moving, then they should call the clinic. The non-stress test is what we just talked about in relation to the biophysical profile. We can do a non-stress test for a multitude of reasons and not do it with the ultrasound as part of the BPP. It can just be, oftentimes for high-risk pregnancies, we will have moms come into the clinic and have non-stress tests once or twice a week. And it is non-invasive. They put a monitor on the outside of the belly. Again, they pick up the heartbeat and they trace it so they can look for variations in the heartbeat. And truly, this is the most widely accepted fetal evaluation for well-being and oxygenation. There's a lot of things that we'll learn about that really show us on that tracing if we're concerned, if the baby's not well oxygenated, if we're worried that the baby's acidotic, things like that. And so we are looking for a reactive tracing. The contraction stress test is similar to the non-stress test, except with a non-stress test, we're not doing anything we're just watching. With a contraction stress test, we can actually give mom oxytocin and make her uterus contract, and then we can watch how the baby responds to those contractions. And so contraction stress tests are typically, they're not something that you would do like in the clinic. It would be at the hospital if they were trying to make a determination if they were concerned about a baby and needed to proceed to delivery. Ultrasound. We use ultrasound a lot in OB. This is going to be a very non-invasive way to check on a baby. There's a lot of things we can do for this. The ultrasound is the most accurate assessment of our due date. So even though we use Nagel's rule to determine the due date based on the last menstrual period, being able to look on ultrasound and measure is going to be way more accurate in the first trimester for determining the actual gestational age of the baby. Most often for ultrasounds, we might do one at the very beginning of pregnancy for that purpose. And then we will definitely do one around 20 weeks gestation. And this one is what we call a review of systems, where they look at all of the systems of the baby and make sure that everything is developing properly. For a lot of women, that might be the only ultrasounds they get. It's not something that's done routinely. Okay, but it is available to us for other reasons as well. So we can use it like to check for intrauterine growth restriction. So if they are measuring fundal height and they're getting a low measurement, an ultrasound can look and see how the baby's doing and what size the baby is and if it's growing properly. We can look at the amniotic fluid level. We use it, as we said on the previous slide, for our biophysical profile. We do it more frequently for multiple gestation pregnancies. We also can look with ultrasound to see how long the cervix is, and that can be important, like with preterm labor symptoms. We can use it to diagnose ectopic pregnancies. We can use it for looking for where the placenta is. So like today, we'll talk about a placenta previa, and ultrasound is a great way to diagnose that. And sometimes ultrasounds are also helpful for very obese patients if we are not able to adequately trace the baby's heartbeat, or in order to, even if they have a lot of adipose and they can't even get a good abdominal ultrasound, a transvaginal ultrasound is sometimes used. So there's a lot of different things we can do with this. In the early part of pregnancy, we'll have moms have their bladder full for ultrasound because it's going to help raise the uterus up and make it easier to visualize. Amniocentesis. This is a test that we can do for a couple reasons. This one is invasive, so there's a lot of teaching that goes with this and helping women decide if this is a test they would like to do. So this is something that can detect infection. It can detect genetic disorders, so like chromosomal abnormalities and things like that. And it also can look for lung maturity. And so if we do an amniocentesis, the way that we do it is we clean the abdomen, and you can see in the picture that they put a needle, they use an ultrasound so they can see where's the baby, where's the placenta, and they put a needle into the abdomen in through to where the amniotic fluid is, and they aspirate some amniotic fluid, and then they're able to test that. Risks that can come from this. Early pregnancy, it can cause a miscarriage. Late pregnancy, it can cause preterm labor. Risk for infection. Mostly though, it's the risk of either miscarriage or labor. If we're doing this early in pregnancy, it's going to be to look for congenital anomalies. So if you had a patient that had maybe a low alpha fetoprotein, and low alpha fetoprotein, Down syndrome. Okay, we're worried about Down syndrome. So for that patient, if she had a low alpha fetoprotein test, they might do an ultrasound and look on ultrasound and see if they see anything that would indicate Down syndrome for their baby. But the next step that is the more invasive step, which would be the amniocentesis in that scenario. And that's a decision that in that case, that mom can choose. If my baby has Down syndrome or not, it doesn't matter to me, or I really need to know. Okay. If we do an amniocentesis later in pregnancy, it's typically to look for lung maturity. So if you have a patient who is, they're considering delivering preterm because of her health conditions, maybe she's preeclamptic or whatever, they might want to check and see how mature the lungs are. And so they look at an LS ratio, and they want it to be 2:1, and this, they can see these values from the amniotic fluid as well. This allows us to know if there's sufficient surfactant available within the alveoli. So this is another reason to do it. And again, there's going to be teaching involved in discussing the risks. I also have seen them do it for infection, but not commonly. So danger signs in pregnancy. If we think about all of these things, these are all things that we would want to know about. We are teaching patients to let us know if they have these symptoms. And so sudden gush of fluid from the vagina would be if the water broke. Maybe that's not dangerous if she's term, but if she's preterm, that would not be good. Abdominal pain, epigastric pain, severe persistent headache. So epigastric pain can be similar to right upper quadrant pain, and that and severe persistent headache are both things we can see with preeclampsia. Chills and fever over 100.4, so infection, vaginal bleeding, persistent vomiting. So for persistent vomiting, we're worried about hyperemesis gravidarum. Edema of the face and hands can also be preeclampsia, also true for blurred vision and dizziness. And then painful urination or reduced urine output can be seen with a UTI, urinary tract infection. And UTIs can cause the uterus to get very irritable and can cause some preterm labor stuff. So let's talk first about hyperemesis gravidarum. So this is not your normal nausea and vomiting of pregnancy. With hyperemesis, this is very exaggerated from that. This is actually causes a lot of pregnant women to become hospitalized because that they cannot keep anything down. So they're losing weight and their fluid and electrolyte balance is off. They're dehydrated. They're they have nutrition deficiencies, all these problems. And so some women even need like TPN where they're getting nutrition through their IV. So for nursing considerations for her, we would be considering INOs. We'd be keeping track of what she's taking in and putting out. We would be giving probably anti-nausea medications, IV fluids. We would be teaching her to eat small, frequent meals, doing dry, bland, easy to digest carbs. Also important to do teach good oral hygiene, because if she's vomiting a lot, then that's bad for her teeth. Bleeding for early pregnancy. So there's a lot of different things that can cause bleeding in pregnancy. And so we look at it first, early pregnancy and late pregnancy. So bleeding in early pregnancy, this is going to be something that's happening before the age of viability. And so we consider the age of viability 20 weeks gestation. And so if we have, and I think if I move this over here, you can see the rest of the words on the slide. If we have symptoms of like bleeding and cramping, if she does not actually miscarry or abort the baby, we call that a threatened abortion. So she can have backaches, cramping, vaginal bleeding. If the cervix is still closed and the baby still has a heartbeat, we'll try to maintain that pregnancy. So we will maybe put her on bed rest. We will limit her activity and try to keep her pregnant until she reaches over 20 weeks or an age of viability. If she has a history of having recurrent loss, so she's had several miscarriages before, or several times that she's delivered before 20 weeks, or even if she has a history of delivering after 20 weeks, but in the second trimester, then they might consider something for her called a cerclage. And a cerclage is something that holds the cervix closed for women that have what's called an incompetent cervix, where the cervix just opens when it's not supposed to. And so the cerclage is like the picture on the bottom, where they actually put a stitch all the way around and they tie the cervix closed. But that's really only considered for someone who's had recurrent pregnancy loss. For your patient who is, that would have to be done before it's happening. So if your patient's having vaginal bleeding and cramping and backache now, that's not something we can do now. We would have done it before now. Okay. So other spontaneous abortion things, so that's your threatened one. That one we can still try to keep her pregnant, but the ones that are going to be inevitable, the cervix is open, the bleeding's happening, the baby's delivering. Okay. If some of the products remain inside, then she might have to have a procedure where they go in and they clean it out. So that's an incomplete. And so they'll do typically general anesthesia and go into the uterus. And it's called a D&E, which is dilation and evacuation, or they'll do a D&C, which is dilation and curettage, and they go in and they clean all that out. Okay. And then a missed abortion in here is when the baby passes away, but the body does not expel it. And that also would require a D&E. If the mom is Rh negative, we don't know what the baby was. We don't know if the baby was Rh positive. So that mom should get RhoGAM if she has a loss. Okay. For nursing considerations for her, we are going to provide emotional care. So we're going to talk about kind of the grieving process. And when we look at fetal loss, we're going to treat moms that are having an early loss very similarly to those that are having a late loss if they're on the labor and delivery unit. I do think that oftentimes if they're under 20 weeks, if they go into the hospital, they go into the emergency room. And so how that's treated might be different. But if we have the baby, we are offering them to hold the baby, to see the baby. We're encouraging them to spend time with the baby if they would like to, and things like that. And then we're going to be assessing her bleeding. So she had a placenta, and so that delivers, right? So she will have some lochia or post-birth discharge, even though she was not further along in her pregnancy. So some bleeding here is normal. We're assessing to make sure she's not showing any signs of hemorrhaging. Another bleeding thing that can cause bleeding in early pregnancy is the ectopic pregnancy. And so with the ectopic pregnancy, the fertilized ovum implants, but instead of implanting in the uterus in the endometrium, it implants somewhere outside of the uterine cavity. So most often this happens in the fallopian tube, but it can be like in the cervix and things like that as well. If it implants in the fallopian tube, we have to remember that this is very vascular. And so these cells are still dividing, it's still growing. And so oftentimes she will have abdominal pain. And so if she has abdominal pain and comes in, oftentimes we can catch it before it gets to the point where it can be a bleeding issue. Because if we don't catch it in time, it can actually grow to where it ruptures the fallopian tube, and then she can bleed into her belly, and it can be a hemorrhage. Okay. This is one thing we can diagnose with ultrasound. And if she is having severe, like referred pain to her shoulder and signs of shock, then we're worried that she's bleeding in her belly. Okay. If the fallopian tube hasn't ruptured, they can often treat this with a medication called methotrexate. And methotrexate stops the cells from dividing. So it ends that process so that it doesn't continue to grow. Otherwise, she might need to have surgery. So how we take care of her as nurses is going to be dependent upon what they end up doing to resolve her issue. So we might be monitoring her like post-surgically, but we also are watching her bleeding. We are also assessing her pain, and we are also facilitating her grieving process if she's having a hard time. Because that women that have ectopic pregnancies, this is a pregnancy, and it's a loss to them. Some women, it's not. It's like, okay, but for some, this can cause some profound sadness. The gestational trophoblastic disease, or the molar pregnancy. With this one, what happens is that the egg that gets fertilized is lacking in genetic material. So instead of dividing like normal and growing like it's supposed to, it creates this very prolific where a lot of cells are dividing, but they're not making things that apply to a baby. This isn't an embryo. And they divide much faster than if it was a baby. So typically what we would see for her is no heartbeat, because there's not a heart, high HCG level, rapid uterine growth. So the uterus is growing is bigger than we would anticipate for the number of weeks she thinks she is. And then also she also will have symptoms of hyperemesis and elevated blood pressure a lot of the time, and then bleeding. So on ultrasound, it looks like a snowstorm pattern, or if you saw it, it would look like a cluster of grapes, and this has to be removed. So again, it would be dilation, evacuation under anesthesia. We're still going to give her RhoGAM also and assess for bleeding for her. This mom also thought she was having a baby. Okay, she had missed her period. She had high HCG levels, so she had a positive pregnancy test. And so there can be grieving that happens with this as well. The thing with these cells is that they divide so rapidly, and that sometimes it's hard to get a handle on it. And so sometimes I have heard where they've even had to treat this with medications similar to treating like cancer cells. So bleeding that happens late in pregnancy. So there's two big ones that we think about for this, and they're related to the placenta, because the placenta is very vascular, right? All of mom's blood supply comes through the uterus to the placenta, and then the placenta takes the nutrients and the oxygen and sends it through the umbilical cord to the baby, and then the wastes come out back to the placenta, and so on. So there's so much blood flow going through there. And so anything that disrupts the placenta can cause a ridiculous amount of bleeding. So the first one we look at is the placenta previa. And with the placenta previa, the placenta is implanted low on the uterus to where either an edge of it or the whole placenta covers the internal os of the cervix. So anything then that disrupts this is going to potentially cause significant bleeding. So for a placenta previa, if she's bleeding, it's not painful. Her uterus is soft. She's not having pain. She just notices blood in her underwear or running down her legs or whatever. If you have a patient that comes in and she does not know where her placenta is, because oftentimes when they have their 20-week ultrasound and they do the review systems, they'll say, okay, and then the placenta is anterior, or the placenta is fundal, or whatever. If she has painless bright red bleeding, we should notify a provider. Very important that we don't try to check her cervix, because if I put fingers through the cervix, I'm going to bump a placenta and I'm going to make a big bleeding problem. Okay. They can use ultrasound to diagnose. We can look at the ultrasound and see where the placenta is. If she has a placenta previa, she will not deliver vaginally. Okay. Because the placenta is in the way of the cervix. That doesn't mean that she has to have a C-section the minute we figure out she has a placenta previa, but as soon as she either is bleeding heavily or in labor or close to term, they'll schedule a C-section for her. But then if she's bleeding, we might have to do it urgently, emergently. So it just depends, but she will deliver by cesarean. Okay, placental abruption. So this happens when the placenta starts to separate from the uterine wall. And this is not supposed to happen before the baby's born. This happens because of things like trauma. So like if she's in a car accident or she's a victim of intimate partner violence. I've seen it though where, her toddler jumped up and plowed her in the stomach. Or I had one that fell off a horse, which I don't know why she was on a horse at 30-some weeks gestation. But so anything like that can cause a placental abruption. Also true that mom's blood pressure, if it's very high, that can also cause a lot of resistance where the uterine wall and the placenta meet, and can cause it to abrupt as well. Okay. Placental abruption has pain. So our previa was painless. Placental abruption is painful. You can see a hard, rigid abdomen. We say board-like because it's so rigid, and pain for mom. Typically with your placental abruption, the bleeding is dark red, where with your previa, it's typically light red. And if we have a placental abruption, how the baby is doing is going to depend on how significant the abruption is, because for however much the placenta is separated, the blood that would be going into that part of the placenta now isn't. And so the bigger degree of separation, the bigger problem for baby. This baby probably is also a C-section, unless we're like seconds from delivery. Sometimes we get a placental abruption in labor. Rare. But most of the time, this would be a C-section also. And so if they're hemorrhaging, it's an emergency. So DIC, or disseminated intravascular coagulation. This is something that can happen if we have a significant amount of bleeding. Okay, so what happens with this is it's called a consumptive coagulopathy. And our biggest cause in OB of DIC is your placental abruption, but we also see it frequently with postpartum hemorrhage. Okay, so the consumptive coagulopathy, what happens with this is that we get an overreaction of the clotting cascade and all of the clotting factors get used up. And so every place that could clot doesn't. So we get widespread bleeding, and we also have widespread clotting, which makes no sense, but this is what's happening. So we have microclots happening throughout the body with the clotting factors. And then everywhere that we would need clotting, we have none. So we can see bleeding anywhere. So IV sites, injection sites in the urine, where we have a blood pressure cuff that's squeezing and squeezing, those little capillaries can break, and we can see petechiae in her arm. Also signs of hypovolemic shock. So hypotension, tachycardia, diaphoresis. Okay. This is super bad. And people definitely can die this way. If your patient is in DIC, they are getting a lot of blood products, but not just blood. They're getting coagulation factors given back. So they're getting fresh frozen plasma, they're getting cryoprecipitate, you're getting lots of IV fluid. We're trying to stay ahead of it, but we also have to correct the underlying cause. So wherever the bleeding is coming from, we have to stop the bleeding. So if it's your placental abruption, then we need to hurry and deliver her. So signs and symptoms of hypovolemic shock. So our very first thing we will see as a vital sign change when a woman is hypovolemic is going to be tachycardia. Even before that blood pressure drops, as she's becoming more and more volume depleted, her heart is going to start beating faster. Okay. Also true that the blood pressure will go down because there's less volume in the vessels. We can see tachypnea, where her respiratory rate increases because she's trying to oxygenate those tissues. Her breathing can also become shallow and irregular. She will look pale or dusky. Urine output goes down less than 30 mLs per hour or is non-existent because she's not perfusing her kidneys. She can feel really thirsty because she's really dry, cool and clammy skin, diaphoresis, feeling faint or losing consciousness. And the baby, if she's still pregnant at this point, then the baby can have variations in the fetal heart tracing. Okay, hypertension in pregnancy. So for hypertension during pregnancy, there's a few things that we consider here. If she was hypertensive before she got pregnant, then she has a condition. She has chronic hypertension. Okay. If she develops high blood pressure before 20 weeks gestation, she's still considered chronic hypertension. So sometimes you can develop a gestational hypertension, and that's caused by the pregnancy, but that's not going to be something that we see before 20 weeks, right? If she develops hypertension after 20 weeks gestation, that now is a gestational hypertension. So with gestational hypertension, we get onset after 20 weeks. The thing that matters to distinguish gestational hypertension from preeclampsia is that with gestational hypertension, she won't have protein in her urine. When we think about hypertension, we're thinking about greater than 140 systolic or greater than 90 diastolic. And remember, guys, that it doesn't have to be both. It doesn't have to be 140 over 90. If she's 138 over 92, that still counts because the diastolic is greater than 90. Okay. Risks that are associated with gestational hypertension are things like developing preeclampsia. But she can also, if her blood pressure gets really high, she could have a placental abruption. And then we can also see things like kidney injuries and stroke and things like that. Babies are at risk for IUGR where they don't grow as well. So anytime that mom's hypertensive, it affects the way the blood flows to the placenta. So it affects the way the baby grows. And it can also increase her risk of preterm birth. Excuse me. So that's gestational hypertension. So after 20 weeks, no protein in the urine. The thing that we worry about is more significant is preeclampsia and eclampsia. So preeclampsia, we have the hypertension, and then we have another symptom. So with preeclampsia, what's happening is this starts all the way back at the beginning of pregnancy. And when the spiral arteries reach out into the maternal blood supply to feed the placenta, something triggers an inflammatory response all the way back then. And it continues throughout pregnancy and becomes worse and worse and worse. And this inflammatory response is what is going to cause all of our preeclampsia symptoms, but they can happen in many different areas because multiple systems are affected. Okay, so proteinuria is the first thing. And proteinuria is, it's not abnormal to have a little bit of protein in the urine, but anything above 1+ protein is concerning. And so if we have hypertension and we have proteinuria, then that is diagnostic for preeclampsia because we have our high blood pressure and now we have one other symptom. Other symptoms that can be included: significant excessive weight gain. So this is something where she gains a lot of weight really fast, and that is typically related to holding on to a lot of fluid and becoming very edematous. Okay, in preeclampsia, the cells get leaky and a lot of fluid goes into the tissues. Thrombocytopenia. So thrombocytopenia is low platelets. If the platelets are less than 100,000, then that is a sign of another symptom of preeclampsia. Cerebral and visual symptoms. So these are very commonly what we see. And so most often it's either blurry vision, spots before their eyes, or this unrelenting headache, and it's usually in the front like this, and it's just I've taken Tylenol and it just won't touch it. Okay, so it's not abnormal to have a headache when you're pregnant, but if Tylenol's not relieving it, then that can be a sign. Okay, hyperreflexia. So if we elicit a deep tenon reflex, it can be very exaggerated response. Also true, we can see what's called clonus. And clonus happens if we dorsiflex the foot and then let go, we expect it to drop like this. With clonus, it twitches. And the number of times it twitches before it gets to its resting point is the number of beats of clonus that you have. And this is an indication of a very irritable neurologic system, which is concerning because the big thing we're worried about, guys, with preeclampsia is seizures. And so if she's very hyperreflexive and she has clonus, that can be an indication that her neurologic system is very excitable. And I really don't want her to have a seizure. Okay. Other thing we can see is right upper quadrant pain. So when we were looking at the danger signs and we talked about how epigastric pain can be the way that they view right upper quadrant pain. Right upper quadrant pain is caused by the liver because the liver lives over here on the right side. And as with preeclampsia, oftentimes a lot of the red blood cells and are getting broken down and the liver's trying to clean them up and it's getting really overworked and expanding and putting pressure on its capsule can cause a lot of pain. And that is even true worse so with HELLP syndrome. So with preeclampsia and eclampsia, we do not want her to have a seizure. That's kind of the point. So we're going to treat this with a medication called magnesium sulfate. And magnesium sulfate is a CNS depressant. So it takes all of this craziness that's happening and brings it on down. But we have to be careful with this because we can suppress things too much, which we're going to look at in a minute, okay? So the idea is to prevent the seizures, so we give magnesium sulfate. The other thing that, in addition to preeclampsia, that she can develop, it's called HELLP syndrome. This is a variation of preeclampsia, but you don't automatically have HELLP syndrome if you're preeclamptic. But if you have HELLP syndrome, you are preeclamptic. If that makes sense. HELLP syndrome is an acronym. So we have hemolysis, elevated liver enzymes, and low platelets. And so hemolysis, the red blood cells are getting broken apart. Elevated liver enzymes, the liver's working really hard. And then low platelets, thrombocytopenia. So we can see those lab values similar in preeclampsia, but in HELLP syndrome, they're significantly worse. Okay. And there's a concern about her liver and concern about bleeding. Sometimes women with HELLP syndrome have thrombocytopenia so badly, like their level is so low that they can't even get an epidural for labor. So we're gonna skip this slide because we're gonna do that in class. Nursing considerations for preeclampsia. So if your patient is preeclamptic, we really want to keep everything very calm and non-stressful. So we're going to keep the lights low. We're going to minimize the number of visitors she has. We're going to minimize stimulation. Okay. We typically will put padding on the side rails of her bed in case she has a seizure. Okay. We're going to encourage her to rest as much as possible because that's also going to help her blood pressure. And we'll have her resting on her left side to maximize blood flow to the placenta for the baby. We will be prepared in case she has a seizure. So if she had a seizure, an eclamptic seizure is a full-blown tonic-clonic convulsion. And so safety is important, airway is important, okay? So we will be prepared to help with that. And then after the seizure, then we can put oxygen on her and whatnot. Usually we'll turn her on her side so she doesn't aspirate if she vomits, and we keep her safe on the bed. And then when the seizure's over, we can give her oxygen. And then we're going to manage her blood pressure. So the medicines we usually use for this is hydralazine, labetalol, and nifedipine. And more often, IC-labetalol is the first line drug, and then we use the other two as needed to keep the blood pressure manageable. So magnesium sulfate, this is the medicine we use to prevent the seizure. And we give it IV. We give between a 4 and 6 gram loading dose, and then she gets usually 2 grams per hour. And she's going to stay on magnesium sulfate IV until 24 hours after the baby's born. Because remember that this all started with the beginning of the placenta. And so the baby's going to deliver, the placenta is going to deliver, and then we need to give her body time to start healing. And so we're trying to prevent a seizure in that high risk time. So 24 hours after delivery. Magnesium sulfate is excreted by the urinary system. So if she's not putting out at least 30 mLs per hour, she can be hanging on to too much magnesium sulfate. And if she doesn't metabolize through it appropriately, she can actually develop a toxicity. So we need the urine output to be at least 30 mLs per hour. So we're watching for that. We do continuous fetal monitoring while she's pregnant. But the magnesium sulfate is a CNS depressant, and it does cross through the placenta. So we will oftentimes see a baby that looks like they're kind of sleepy on our tracing. We're monitoring vital signs every 15 to 30 minutes. We might still need to give labetalol, hydralazine, and nifedipine to help control the blood pressure. And then we're doing neuro checks every hour. So we're assessing her level of consciousness. Okay. In addition to that, we are looking at how her other organ systems are doing. And so we're checking deep tendon reflexes. So remember, we could have had clonus and we had hyperactive reflexes. But now on magnesium, that should normalize. So her deep tendon reflexes should be normal. But if they're absent, that's too much, right? We're watching for her respiratory rate, because since magnesium sulfate is a CNS depressant, it can also depress the respiratory system. And so we're looking for signs of respiratory depression. We're listening to lung sounds. We're checking for clonus. If she has a dangerous level of magnesium sulfate, signs and symptoms of toxicity, absent deep tendon reflexes, respiratory depression, urine output less than 30 mLs per hour, she can go into cardiac arrest. She can go into like completely apneic, where she's not breathing at all. And if that were to happen and you were like, if she had symptoms of toxicity, you would turn the magnesium off and give calcium gluconate. And calcium gluconate is our antidote. Calcium gluconate, though, is going to push the magnesium off the cells. And now we're back to being at risk of having a seizure. So calcium gluconate is usually a standing order that says give calcium gluconate if, and they'll say respiratory rate less than whatever or whatever. Unless you think she's trying to die right now, I would talk to the doctor and I'd turn off the magnesium, say, hey, this is what I'm seeing. Do you want me to give calcium gluconate? Okay. It's normal with magnesium too for them to feel kind of crummy. They can feel hot and flushed and diaphoretic. And we will oftentimes do like ice packs and cool cloths and stuff like that to help them cope with that. The other thing that magnesium sulfate can do, though, is it can decrease the tone of the uterus. And so that's going to matter a bit for if we're trying to get her into labor, but it matters a lot postpartum because that can increase her risk of bleeding. So effects on the baby with preeclampsia. We can see fetal hypoxia because the preeclampsia affects the way the blood flows through the placenta to the baby. So it can cause hypoxia. It can also cause intrauterine growth restriction because we're decreasing the nutrients over time. We can see meconium stained fluid because the meconium is the baby's stool, and when they become stressed, they can pass meconium. And if they do it in utero, then it can mix with the amniotic fluid. They can also then breathe it in and develop meconium aspiration syndrome. So that's bad. Skin peeling and fetal death. All right, blood incompatibility. So there's a few things for this. The one that we spend the most time focusing on is RH. Okay. And so, and we've mentioned it previously before today, but we're going to go over it again. So RH incompatibility is when the mom's RH negative and the baby is RH positive. And so the mom's body sees the baby's red blood cells as foreign because of the positivity. And the mom's body makes antibodies. With RH, though, this does not happen until delivery, typically, unless there's like trauma. So we don't see these antibodies affecting the baby until she gets pregnant again. And with the next pregnancy, if that baby is also Rh positive, that baby has the risks on the slide. So that baby has a risk of becoming severely anemic and developing erythroblastosis fetalis, where the antibodies get on the baby's red blood cells and break them all down. Okay. And so this is hemolytic disease for the baby. What we would see for that baby is significant hyperbilirubinemia or elevated bilirubin, because the bilirubin is a byproduct of the breakdown of the red blood cells. And so those babies would become significantly jaundiced in a short period of time. So we give RhoGAM to keep that immune response from happening. And RhoGAM is given at 28 weeks gestation, and then we give it within 72 hours after delivery if we find that the baby is indeed Rh positive. Okay. ABO incompatibility is a little bit different, and it's the ramifications aren't as severe typically. So what happens with ABO is that mom's blood type is O, and baby's blood type is anything else, A, B, AB. And so in this situation, this is not where the mom becomes sensitized based on the baby. This is that the mom could already have naturally occurring antibodies to those other antigens A and B. And if that's the case, then those antibodies can cross the placenta and attack the baby's red blood cells and cause hemolysis for the current pregnancy. And those babies also then are at high risk of having jaundice and anemia. So what we can do is we can test, we can either test mom and look at an indirect Coombs test to see if her blood has the antibodies. And then after delivery, then we test the babies and we can see if the antibodies from mom are on the baby's red blood cells. Okay, so that's either indirect Coombs and direct Coombs, or we also can see it as a DAT, so a direct antibody test. Okay, but all of these are going to break down the baby's red blood cells and cause jaundice. Diabetes. So with diabetes, we're thinking about, we can have a patient who had diabetes before she got pregnant, and that's a pre-gestational diabetes. Okay, we will not be screening her for diabetes during her pregnancy because we already know she's diabetic. All right, and with diabetes, this can, how she grows her baby is going to be largely dependent upon her glucose control. Right. For gestational diabetes, this is going to be where moms develop a glucose intolerance during the pregnancy. It's a gestational issue, and it resolves after the baby's born. So she still develops an insulin resistance. Okay. And so for gestational diabetes, oftentimes they can be diet controlled, but sometimes they need insulin also. For women who were not diabetic before they got pregnant, we screen them between 24 and 28 weeks gestation. It's called a glucose tolerance test. And so they get the 1 hour glucose tolerance test. They drink a very sweet drink, and then at 1 hour, their glucose level is checked. If that value is elevated, then they will have them do a 3 hour glucose tolerance test where they again drink the very sweet drink, and then they check their blood sugar at 1 hour, 2 hour, and 3 hour interval, and determine then if they have gestational diabetes. So the way that diabetes affects the pregnancy, for the mom, it increases her risk of other things. So increased risk of gestational hypertension, increased risk of preeclampsia, increased risk of preterm labor, also increased risks of infection. If she's not managing her glucose levels well, she can also grow a baby that is pretty large, so that can increase her risk of either needing to have a cesarean to deliver her baby if her baby's too big to fit, or injuries to her perineum and that with delivery. Okay. Also, moms that are diabetic can have develop ketoacidosis. And the threshold to develop ketoacidosis is much lower in pregnancy than it is if you're not pregnant. Okay. For the baby, babies that are conceived to moms that have diabetes before they get pregnant and have poor glycemic control have a higher prevalence of congenital abnormalities. So what I mean by this is if she isn't controlling her blood sugars well and she's diabetic when she gets pregnant, those babies are the ones that can have cardiac problems and other congenital problems. If she is a gestational diabetic, those babies won't have the congenital risk because she didn't develop her diabetes until after those organ systems were formed. Because remember that our organ systems were formed in the embryonic period, and she wasn't a diabetic yet at that point. Okay. Complications for baby includes that large size. So we call that macrosomia. That baby is at risk for birth injuries because the increased risk of like shoulder dystocia. Okay. Conversely, those babies can have an intrauterine growth restriction. So it just depends. Babies that are born to diabetic moms have a risk of respiratory distress syndrome. And this is because that when the mom is diabetic, if she doesn't have good glucose control, her body is giving a ton of glucose to the baby because the glucose readily passes over through the placenta. But the baby makes its own insulin. Okay, the insulin doesn't cross over. So the baby's body is producing lots and lots and lots of insulin to combat all of this glucose. And if the baby's body makes insulin for a long period of time at high levels like that, it affects their surfactant production. And so that can affect their lung maturation and cause respiratory distress when they're born. Biggest concern that we worry about right after a baby's born to diabetic mom is neonatal hypoglycemia. So because the baby's body is making so much insulin, when the baby's born, we clamp the cord and now they're not getting any of that glucose from mom anymore, but their body's still making a lot of insulin. So these babies have a high risk of becoming hypoglycemic. Okay. Also, these babies are at risk of hyperbilirubinemia and jaundice and polycythemia, and in rare cases, perinatal death. So how do we take care of our diabetic mom? During pregnancy, we are going to teach her how to take care of herself. So we're going to teach her how to choose healthy foods. Okay. She still needs to eat carbohydrates, but they need to be healthy carbs. Okay. She still needs carbs to grow a baby. But healthy food choices, we want her to keep her glucose levels at a steady amount. So it's the peaks, it's this that goes where the glucose has spikes and peaks and troughs, that's what really drives macrosomia. So we want to teach her how to keep her blood glucose levels nice and even. So eating frequently throughout the day, small meals, exercising after meals to control her blood sugar, checking her blood sugar frequently throughout the day. So teaching her how to use a glucometer. Also teaching signs of hypoglycemia. Okay, so we don't want the peaks and the troughs, but we're teaching her how to recognize if she's hypoglycemic and is feeling weak and trembly and sweaty and stuff like that. Okay, we're also providing good education about how her insulin needs are changing as pregnancy progresses. So in the first trimester, pregnant women that are diabetic typically have pretty good glycemic control. In fact, sometimes they can become hypoglycemic. And that also happens after the baby's born when they're breastfeeding. Okay, as her pregnancy progresses, her insulin needs are going to go up. And because her body becomes more and more insulin resistant. So by the third trimester, her insulin needs could be 2 to 4 times what they were before. All right. And then as soon as the baby's born, very quickly, her insulin needs go back to pre-pregnancy. Um, and and also then then if she's breastfeeding, maybe even less. All right. During this pregnancy, this is a high-risk pregnancy. So we're doing ultrasounds, we're doing non-stress tests, we're teaching her to do daily kick counts. Okay. In labor, we're going to continuously monitor the baby. We're going to check her glucose levels every hour. Some women are needing an insulin drip during labor because that their insulin needs are so sporadic and all over the place. Some women in labor become hypoglycemic and need to have dextrose. Okay. We need to be prepared for the macrosomic infant, so a baby that's very big. So possible that she needed a C-section because the baby was big and they were concerned about the fit. If we're delivering vaginally, then we have an increased risk of birth injuries, and we have for both mom and baby. And so we're preparing for that. We're also prepared for the fact that when the baby is born, we're watching those blood sugar levels really closely. And we're also watching the baby's respiratory status for all the reasons we said on the previous slide. For neonatal hypoglycemia, in addition to watching the glucoses, we're feeding that baby really regularly. So most hospitals have an algorithm you follow, and you have to get a baby eating by a certain time, and you have to feed in certain intervals, or at least offer or try to maintain the glucose levels. Heart disease. So heart disease is something that women can just have in life, and then they've now become pregnant. And we need to think about the fact that if any woman, remember that their blood volume goes up significantly in pregnancy. And so if you think about what can stress a heart, that could definitely do the trick, right? So we want to minimize stress in the heart because we already have this huge amount of extra blood volume. And so we're teaching her things like limiting her activity and avoiding straining when she goes to the bathroom and things like that. We're going to teach her to report things that show signs that she could be decompensating. So if she has sudden onset increasing edema, feels like her heart rate is racing, or if she's having trouble breathing. Okay. Things that we're watching for signs of congestive heart failure. So edema, jugular vein distension, shortness of breath, orthopnea. Okay. Also, like hearing crackles when you listen, moist cough, stuff like that. Okay, these women might be on different medications. So if you are taking care of her, you might be giving her diuretics, you might be giving her beta blockers. In labor for women with heart disease, we are wanting to manage her pain so that it's not ever something that is so severe she's having trouble tolerating. And we're putting her in positions that support cardiac function. So we're still wanting to do left tilts or left sides to help promote perfusion to the placenta, but maybe keeping her head of the bed elevated and not laying her down too far and things like that. Anemia. Anemia is going to affect the oxygen capacity, carrying capacity of the blood. And so with this, we have less red blood cells. All right. And that's what's affecting our ability to carry oxygen to the tissues. And so oftentimes the heart's compensating. We have increased cardiac output to compensate for the anemia. Most often in pregnancy, there's two things that happen that are the most common anemia issues for pregnancy. First is your physiologic anemia, because when the blood volume goes up, more of it is plasma than red blood cells. So women are a little bit anemic in pregnancy anyway for that reason. Okay, but most often if your patient is anemic, more than a physiologic anemia, then it's probably iron deficiency. And so things that we're teaching women that have iron deficiency anemia is going to be how to take iron, right? And so this was discussed with nutrition, but discussing it again, most women are going to need iron for at least 3 months, because that's how long it takes to proliferate the red blood cells, right? The life cycle. So for at least 3 months, they're going to need iron, and in pregnancy, they end up pretty much staying on it through the whole pregnancy, actually. So what to eat, what not to eat? Vitamin C helps absorption. Calcium decreases absorption. So vitamin C juices like orange juice and things like that can help. Things like milk isn't going to help. Tums isn't going to help. Also true that coffee and tea affect absorption. So she shouldn't take it with those either. And then iron can cause their stools to be dark. So we want to teach them about that also. So torch infection. So there's several things related to maternal infection to consider. And our torch complex kind of breaks down most of it. All right. And so these are all infections that can be devastating to the baby. And so this is also an acronym. So T in torch is toxoplasmosis. This is a parasite that's usually found in cat feces. So the things that we're considering with this is we need to teach moms that have cats not to change the litter box while she's pregnant. Okay. Also true that she should be cooking her meats thoroughly, cleaning fruits and vegetables well, cleaning up well after cooking, things like that. All right. Toxoplasmosis does transmit through the placenta and can cause neurologic damage for the baby. The O of torch is for other, and it's going to be a catch-all for things that isn't in the rest of the acronym. So this is things like hepatitis B, HIV, Zika, measles, parvovirus. Okay. For HIV, there's a few things we consider for this. So if we knew she was HIV positive at the beginning of pregnancy, we would have been treating her with an antiretroviral throughout her pregnancy. She also will get it in labor, and then the baby will get it after delivery, and for the first 6 weeks of life. And all of these things are aimed at reducing the risk that the baby it develops HIV. The other thing that we are going to teach moms is not to breastfeed, because it can pass through the breast milk. Okay. Hepatitis B is something that if mom is not hepatitis B negative, then the baby gets we call it HBIG, is hepatitis B immune globulin after birth. Okay. If mom's hepatitis B is negative, then baby's just offered a normal hepatitis B vaccine as part of our baby meds. But if it's positive, the baby gets HBIG. Rubella. So rubella is going to be something that if she is non-immune, we are not able to vaccinate her during the pregnancy because the vaccine is a live virus. So we will vaccinate her after delivery, because then we know she's not pregnant, and we will tell her not to get pregnant for a full month after her vaccine. Okay. We want her to be vaccinated in case she becomes pregnant again. And the concern for babies is that if mom has rubella, that it can have cause deafness for the baby. I've actually known a couple of people that that's why they were deaf. And also can cause intellectual impairments and things like that. Cytomegalovirus, or CMV. This is something that is, there's not a way to treat this that during pregnancy to prevent it. And it is definitely a cause of deafness for babies. So I have a friend whose baby didn't pass the hearing screen, and then they tested, and the baby was deaf, and they tested the baby, and the baby tested positive for CMV. At the hospital I work at currently, if our babies don't pass their hearing screen, we automatically test them for CMV. Herpes simplex. If a patient has herpes lesions in her perineal area, she cannot deliver vaginally while the lesions are present. If babies contract herpes, it is has a really high mortality rate and has a significant prevalence of neurologic complications. So the babies can even develop lesions like on their brains and stuff like that. It's very sad. If she is known to have herpes, then oftentimes women are given acyclovir at the end of pregnancy to try to minimize the chance that she'll have an outbreak during labor. So she could deliver vaginally. Group beta strep. So group beta strep, or GBS, this is something that lives in normal flora. And it doesn't bother women when they have it. You don't know you have it. But it has a high mortality rate for babies if they're born to moms that are GBS positive and it's untreated, up to 50%. So around 36 weeks gestation, 37 weeks gestation, they do a swab of the rectum and the vagina, and they look for this. And if she's GBS positive, she'll need antibiotics in labor. And then that is the best way to protect the baby. If we don't know if she is GBS positive or not, they might treat her prophylactically. Urinary tract infections. So women have a higher risk of urinary tract infections in in pregnancy, because that their bladder doesn't completely empty all the time. And urinary tract infections a couple things can happen. One thing is that it can stimulate the uterus and make it contract. Also, if it goes untreated, it can extend into the kidneys, and she can develop pyelonephritis, which can develop into, she could become septic. It can be a whole big problem. So we typically screen, I want to say, I don't remember how many weeks. They sometimes will just do a check for bacteria in the urine, because that some women can be asymptomatic. And then if she's having urgency, frequency, and burning, then they test more frequently. Some women are on medication through a lot of the pregnancy to keep UTIs under control. Substance abuse. So when we think about substance abuse, the first thing I think of is your heavy hitters, right? Like your opioids and stuff like that. But even smoking during pregnancy can affect the way we grow a healthy baby. We can see low birth weight and intrauterine growth restriction with smoking, because we have this chronic vasoconstriction. With alcohol, women who drink alcohol throughout pregnancy, those babies can develop what's called fetal alcohol syndrome. And this is our leading cause of cognitive impairments for babies. There's not any amount of alcohol that we consider a safe amount for her to drink. And so we discourage the use of alcohol in pregnancy completely. So for substance use disorder, that's where we think about our opioids. These readily cross the placenta, and it also crosses the breast milk. If she's taking any of these drugs, then she should not breastfeed. Okay. If she's on a program where she's taking methadone or Suboxone, Those things are acceptable during pregnancy and breastfeeding. That you will still see withdrawal symptoms though from it. So infant withdrawal, we have to watch very closely. It's a priority to when we're taking care of babies of moms with substance use disorder. And we spend more time talking about this with our newborns and our high-risk newborns. Trauma during pregnancy. So our big concern with trauma during pregnancy is going to be what we said earlier about our placental abruption. Because if we have falls, slip and fell in the ice, car accident, whatever, then we can disrupt the placenta and it can start to separate. Morbidity and mortality for the baby is going to be high, and it's going to be higher. The higher it gets related to the degree of separation. Oftentimes we can see on our fetal heart tracing signs that could indicate that the placenta is separated because it's affecting the blood flow to the baby. If you have a patient who needs CPR, we have to prioritize the mom's resuscitation over the baby's. With CPR, it's important to, if you think about what we learned about with supine hypotension, right? And we have the vena cava that's running behind the uterus, and if she's on her back for CPR, the uterus is putting a ton of weight on the vena cava, and we're not going to get good blood flow with compressions like that. So somebody has to put their hands on the belly and pull the uterus to the side so that we can get good CPR. And truly, if we don't get a mom back in the first few minutes, they do an emergency C-section, because it's hard to compress, like get good blood flow and do good compressions with a baby in there. For choking, if a woman is pregnant and choking, instead of doing your traditional Heimlich, you're going to bring this up to the chest and do chest thrusts instead because of the placement of the uterus. So when we think about how a high-risk pregnancy affects a family, there's a lot of different things that we play into this, right? So sometimes she's not working, all the medical bills are piling up, it affects the way, it can affect the way that they bond with their baby. Because depending on how the baby is at delivery, maybe the baby isn't skin to skin with mom, maybe the baby's whisked away, maybe the baby goes straight to the NICU, whatever. And there is a lot of things that kind of feed what we call birth trauma psychologically. And loss of your expected birth experience is part of that. So you have idea of what you anticipate is going to happen, and when that doesn't happen, some people really kind of mourn that. So we're going to finish by looking at grieving. All right, and so we're going to look at early loss and loss of experience, and then how we take care of like stillbirths. Okay. So the things that are going to be important, regardless of the gestational age of the baby, is going to be allowing them time to have privacy, allowing them time with the baby, allowing them to have visitors if they would like to participate in saying goodbye. We need to support and help them understand that all of the confusing feelings they're feeling are normal. And we can do things as nurses to try to not only help them in this moment, but to give them tangible mementos they can take home. So oftentimes we will take the baby, or even do it in the room, and do footprints, photos, locks of hair, depending on gestational age, weights, measurements, all sorts of things that make it tangible. If the baby is closer to term, oftentimes then some of these experiences In addition to holding, we might want to consider, trying to see what's on the next slide, we might want to consider letting them participate. This is their only chance to be parents to this baby. And so I've had parents bathe their baby, dress their baby, and I help them do all those things. Um, being able to see, touch, hold, bathe, dress, say goodbye. Okay. I'm going to tell you guys that this is something that is really taxing on the caregiver. Okay. So definitely important that because as nurses, we are very empathetic, right? And it's important that we also take care of ourselves after taking care of a patient that's going through these hard times. Okay. All right. I guess that's it for this week. I hope you guys have a great day.